Hi, I'm Eddie Martucci. I am the pharmacy manager at the Walpole Big Y, and as part of our community outreach program, we do lunch and learns. And most times they take place at the Walpole Council on Aging, but today we are here at Walpole Media. Thank you to Walpole Media for accommodating us. And I'd like to give a little presentation today about Medicare Part D explained kind of. There are a lot of questions about Medicare and Medicare Part D when we turn 65. What are our options? Do we have to take it? And hopefully after the presentation we'll have some answers for you. Medicare Part D, as a little bit of a history, was part of the Medicare Modernization Act, and that's the Part D part for the drug part. It was enacted January 1st of 2006. It was private insurance companies were tasked with providing prescription benefit medications, paying for the medications for those of us over the age of 65. So it was voluntary at the beginning, and those are called pharmacy benefit managers, or PMBs or PBMs, however you would like to say it. It was a voluntary program starting in 2006. The premiums came from public and Medicare funds or CMS funds. In 2010, with the act that went through called the Affordable Care Act, also known as Obamacare, it became a mandatory process. And what does that mean for us when we turn 65? It means that at age 65, we have a 3-month window where we have to sign up for a prescription drug plan or Part D plan of our Medicare coverage unless we already have a plan that gives us at least as good coverage for our medications or better than what is offered by any of the Medicare pharmacy benefit managers. So our grace period is 3 months from turning 65. Now most of us at 65 are still working, or maybe we've retired and we have a pension plan. So normally your employer, if you have a pension plan, will give you a grace period, and then they will turn it over to a Medicare Part D, but they will most times keep the same rules and regulations that they offered you when you retired. There is a penalty of 1% per month of a surcharge if you do not sign up on time. So for every month that you do not sign up when you are eligible, you get charged 1% more on your premium for the rest of your life. So for instance, if you didn't sign up for a whole year after you were eligible, there would be a 12% penalty added to your premium every month thereafter that you would have to pay. And normally that comes out of your Social Security check. So why didn't everybody sign up when the time was right? It was mandatory. Well, most of the reasons are on the next slide. We see that folks only took 1 or 2 different generic medications. The basic plans cost $42 a month out of their Social Security checks. And back in 2010, when it became mandatory, most medications that were very inexpensive generics used to prevent disease like high blood pressure, diabetes, or high cholesterol, you could get a 3-month supply for $10. So for $40 for one medication for the whole year, you would be able to pay for your medication. Even if you took 3 medications, that's $120, which would be eaten up in less than 3 months if you signed up for a Medicare Part D plan. Most of the people that when they turn 65, as I mentioned previously, still are working, so they have private insurance to cover their prescription needs. And there weren't really many ridiculously priced medications. But that pretty much changed. So we're going to talk how Medicare D works. On the next slide, it gives us our complicated slide of what our payments are based on the dollar amount that we've spent on our medications starting at the beginning of the year. It starts at the beginning of the year, January 1st of each year. So from $0 to $545, these are 2024 prices, and it's percentages of what you would pay. So from 0 to $545, you have the deductible. So you are responsible for the medication costs for the prices that the pharmacy benefit manager would pay. Most people would pay less than they would if they paid cash. Cash prices are much higher than what the insurance companies bargain with the pharmacies for in the rates that they negotiate. And then from $546 to $5,029, you have deductibles. Normally there's 4 tiers of deductibles. So your first tier is normally your generic medications, and then there's a tier for your brand name medications that the insurance company prefers. There's a tier for brand name medication that the insurance company does not prefer. And then when you're in tier 4 or 5, if there is a 5th tier, most of those are percentages. Most of your tier 4 drugs are a 25% cost payment, and most of your tier 5 drugs are 50% cost payment. Once you get past $5,030 all the way to $8,000, you are again responsible. That's the dreaded donut hole of Medicare Part D. So again, you are paying out of pocket for that. And then after $8,000 of medication spent for you in the course of a year, you're in the catastrophic coverage. You're back to copays, and normally those copays are less than what you've paid previously. On the next slide, we see that, as I've said before, it begins January 1st, it's calendar year. The premiums are paid out of your Social Security check monthly if you're collecting Social Security, or they can be paid by the employee retirement plan, or you can pay them yourself. The premiums are, to begin this year, the very basic plans for 2024 are $55 per month. And there is a thing called an Advantage plan. What an Advantage plan does, and I'll talk about that in the next slide, what an Advantage plan does is it links your Medicare A benefits, Medicare B benefits, and your Medicare D benefits. A is your hospitalization. B is things like doctor's offices, lab work, and certain medical devices and home health care aids, like diabetic testing supplies is the most common. That would be linked into B. And D is our drug part. The advantage of having a Medicare Advantage plan is that it combines all 3, and normally they do not charge you any extra out of your Social Security check. So if you are taking just basic medication to prevent a disease, something like high blood pressure or high cholesterol, you would probably go with an Advantage plan because it wouldn't cost you anything else. Most of the Medicare D plans, as most of our regular insurance plans do now, for those types of medications, if it's a very low price generic that's used to prevent a disease state, there is normally a $0 copay for a month or a 3-month supply if you go to a preferred pharmacy. So an Advantage plan might be very welcome for somebody who is in that category. But if you're in a category where maybe you're taking 2 or 3 inhalers for COPD or emphysema or asthma, that may not be the best choice because those inhalers are normally $200 or $300 a piece. The only real changes that it would affect in our normal lives is that it does change where we can go to have our blood work drawn for our lab work, and it will change what testing supplies, as I mentioned earlier, that would be covered under Medicare B if you had it by itself. But if you join an Advantage plan, you would have to go to the testing supply system that the Medicare D plan you chose offers. And it also would change coverage for nursing services later on in life if you should choose to use those. So why do we have all these copays and deductibles? Well, that's a very complicated chart that I showed you a few slides ago, and we would like things to be simpler as we get older. I know I would like things to be simpler as I get older. Well, based on our tax structure in 2010 when they made it mandatory, they found that our tax structure could only support the medication needs of about 17% of the population over the age of 65. So they had to come up with another way to fund payment of the medications for the rest of the people. And they did that by privatizing insurance. And we know the insurance is great, we need it. If we really need it, it's there for us. But insurance companies really aren't doing it out of the goodness of their heart. They're companies, they're businesses, they need to make profit. So what happens when you look at the payment scheme on this schedule, those people to the left, the Medicare D patients, pay their money, or Medicare pays their money, into the pharmacy benefits manager, and then they pay the pharmacies the money when somebody goes and gets a medication. So if you came into my store and you got your Advair inhaler, I would bill the Advair inhaler to the PBM, and then they would pay me. Normally in 14 days they pay the pharmacies. So the PBM stands for Pharmacy Benefits Manager. They collect the money from the clients, They pay out the pharmacies, but the really important thing is that they set all the prices. So if you go in and your copay is $50, that money isn't what the pharmacy set. We would rather have everybody pay nothing and make sure they had their prescriptions covered. But it's up to the pharmacy benefit manager to set what the copays are, and they set how much the pharmacies are paid. And we'll talk about that in a couple of slides. They pay the pharmacies based on AWP, and I'll identify what that means in a minute. So they take the average wholesale price, that's what AWP stands for. They subtract a percentage and then they add a fee for service. And those percentages that they subtract off of that price varies based on the class of drugs that they're in. Now the AWP is something that the manufacturer of the medication sets, and it's supposed to cover the cost of bringing that drug to market and what it costs to manufacture that drug and produce it for the public. But it also covers the cost of failed medications, and we're going to talk about why it costs so much to bring a drug to market in a minute. The PMBs, though, because of the HIPAA laws, and we'll identify that in a sec, the privacy practice laws, they can make a deal with a manufacturer for a rebate on the medications if they are a preferred manufacturer. They can make a deal with the pharmacy as to how much they're going to pay, and then they can make a deal with the pharmacies that they're paying, and they don't have to tell any of the other interested parties what deals they've made with party A versus party B. To set an example, if PMB looks at wholesaler A and says, I'm going to use your drugs, and wholesaler A says, that's great. If you're going to make my drugs preferred, I'll give you a penny savings on each tablet that you pay for, but my pharmacy can buy from B better than A, then the PMB will go back and charge that money to me because they want that profit margin. And they don't have to, as I've said before, this next slide just says they don't have to share any of that other information. So it's almost like pharmacies aren't on the same playing field as the PMBs and the drug manufacturers for reimbursement because we don't know what kind of deals are made. Here are the definitions on the next slide that I was going to talk to you about. HIPAA, which stands for the Health Insurance Portability and Accountability Act. And that's when you first go to any new pharmacy, or every couple of years, you have to sign a HIPAA waiver. Or when you go to your doctor, you have to sign a HIPAA waiver, or a lab. And what that means is they can't share your information with anybody other than you or your treating physicians. Average wholesale price, as I said, is an arbitrary number that's set by the manufacturer, and it's supposed to reflect the cost of the medication and the product that they have in that bottle. On the next slide, we talk about what is the cost of the drugs. What does it cost to bring a drug to market? In 2014, it was shown that it cost almost $2.5 billion to bring a medication to market. $1.4 billion out of pocket of the manufacturer, and about $1.1 billion in returns to investors. From the day that a manufacturer, one of the big ones we'll pick, we can choose Pfizer or Merck Sharp and Dohme, gets an NDA, which is a new drug application, they have 17 years from that day to make the drug all by themselves without a generic coming out. 7 to 10 of those years are normally chewed up in clinical trials. There are normally 3, sometimes 4 clinical trials. They first start trials on animals, and then normally it's animals that have systems similar to ours. So if you have a medication for the stomach, you're going to work with probably swine or pigs or hogs because they have a very similar digestive tract to what humans have. And then for the next 7 to 10 years after their clinical trials, when that drug is finally brought to market, they have to recoup all the money that they've invested in research and development and get a healthy profit margin before a generic company comes along and doesn't have to do any research and can produce their medication once it goes off of patent. So in 2020, the Tufts Center for Medication did a drug study, and they say that $1.8 billion is what it costs for capitalization. It costs $2 million for a new drug application. It costs about $300 million for each clinical trial, and as I said, normally there are 3 of those. It then costs another $350 million out of ancillary costs. I don't know what they're charging for pencils, but the way sometimes these big companies pay for small things, maybe that's where that money goes. And the study concluded that if a company brings one drug to market that's used for human consumption here in the United States every 10 years, then it costs about $550 million to bring that drug to market, because there will be failures, and we're going to talk about that in the next slide. But if a company brings more than 8 drugs to market in that same 10-year period, each drug winds up costing that company about $5.5 billion. And on this slide, it explains why. 10% of drug entities that start pretrial studies, meaning they've got a new drug application, only make it to get that new drug application. So when they first start studying the drug and they look at the chemistry and they look at how it works on a system, only 10% of them get to be the NDA. And of those NDA drugs that are used, 45% of those fail in the clinical trials. So only 55% of those drugs get to market to be used for humans here in the United States. That's 6% of all the original drug entities that all the manufacturers have thought might be good and useful in humans make it to market. Each failure of a medication that doesn't get there costs about $10 million for the drug companies. The next study just explains how those 94% of medications failed. 40 to 50% of them failed because of a lack of clinical efficacy. In real, regular language, that means they just didn't work. 30% were unmanageable toxicity. Again, back to simple language, it means that they had side effects that were intolerable or people just couldn't live with. 10 to 15% is interesting, that they lacked increased commercial need. So maybe it did everything it was supposed to do and everything went well, but when they went to market, it was for such a small population that the doctors that prescribed those drugs said, you know, we're really not going to do it because the cost is too high, or we don't think that our patient will recover or need that drug by the time we try some other medications. And then 10% is poor strategic planning from the manufacturer. So either they didn't follow all the steps that the FDA wanted them to follow, or they just didn't plan out their marketing strategy properly. The Journal of American Medical Association, JAMA, followed 640 drugs for 10 years. And it shows, this slide just shows the same things. 54% failed, 36% were approved for use in the United States, another 10% were approved for use in other countries. Every country has their own standards for bringing a medication to market for human use. The United States is the strictest by far. So that's why we did not have that extra 10% usage here in the United States. So let's go back to Obamacare and talk about that for a minute. This slide shows my good friend from Back to the Future. If I had my DeLorean, I could just zip out of here with some garbage, put it in the processor. So as I said previously, the PBMs can make rebate deals with the manufacturers per the Affordable Care Act. And actually it was also conjuncted with the Medicare Act of 1965. And they can subtract those payment rebates from the pharmacies if they don't use the right preferred generic drug or brand name drug. So as I said before, if I can buy it from manufacturer B at a better price than manufacturer A, I would pay that rebate back to the pharmacy benefits manager at the end of each month. Now that was something that they did called clawbacks, and those clawbacks used to take effect 3 months later. That became illegal for them to do starting in 2024. But now due to transparency, they've added those rebates into their direct cost payments to the pharmacies. So the payments that the pharmacies are getting are a lot less than what they were previously. Pharmacies lose approximately 10% on all brand name medication. And that's because brand name medication is extremely expensive, and the PMBs know that. So what they want to do, and PBMs know that, what they want to do is they want to mitigate their costs. So what they do to the pharmacies is they say, you know what, we understand that you have a losing margin on those medications, so what we will do is we will give you a very large margin of profit on other classes of drugs. Most of those drugs are topical, or they're generics that are not used a lot, or they may be psychiatric generics that are just come to market. Unfortunately, those are the 3 classes of drugs that get hit the hardest. And I'm sure some of you have come across that. You've gone to your a dermatologist because you have a little bit of a mole on your forehead and it's from sun, so your squamous cell carcinoma, the start of it, they want you to go get a medication called Effudex. If you try to bill it through your Medicare Part D plan and you haven't met your deductible, it's about $130. But you can get it with a discount card at Eddie's Pharmacy or Walpole, the Big Y in Walpole, for $45. So by you using that, you're actually taking away the profit margin, and it's not you specifically, I'm not blaming anybody. It's what happens is the pharmacy's losing that profit margin that the PBM said, oh, here's how we're going to make up for you losing on brand name drugs. So back to the Advantage plan and regular Medicare Part D plans. Most of the generic medications that are used to prevent diseases, for the ones that I have listed on this slide, hypertension, diabetes, hypercholesterolemia, just means you have high cholesterol, and cardiac health, have a zero copay. And if you go to a non-preferred pharmacy, you can get it at a zero copay still, but you can only get a month's supply, and preferred pharmacies are allowed to dispense a 90-day supply for you. So we're back to our complicated chart here. And how do we minimize our out-of-pocket expenses? If you use a discount card, as I mentioned in the Effudex example, if you use the discount card and you don't bill that $130 you're paying it out of pocket, but it doesn't go through to your pharmacy benefit manager, whether it's United Healthcare or WellCare or CVS Caremark or Express Scripts, whoever you happen to choose, then they don't know that you've purchased it. So you really never get out of that deductible phase. So if you complain to your insurance company that does your Medicare Part D that, oh, the price is too high, they'll say, oh, use a discount card. Because then if you never get out of the deductible, they're never paying any money for you at all. I want to talk a little bit about discount cards and discount coupons from the manufacturers. By the picture that I have up on this slide, you can see how I feel about them, and I'll tell you the reason why. Most of those discount cards charges the pharmacy, as this slide shows, money to give you the discount. Now, the PMBs have their own discount cards that they will link automatically when we try to bill a medication to your Medicare Part D plan. They will link their own discount card, and if we accept that payment from them as a discount, they charge the pharmacy $20. GoodRx, which is a big one in this area, they do a lot of advertising, and the reason is they make $7 to $10 off that prescription that you're getting a discount on. And Single Care charges $5 to the pharmacy, and et cetera, you can see on there. So the ones that we use at the Big Y is ScriptSave, because that only charges the pharmacy 2%. There's always a cost for the pharmacy to use a discount card, because the discount card has to pay different costs. And some of those costs that they pay go directly to the pharmacy benefit managers, because they are buying the list of pharmacies that use them to process prescriptions for you in a legitimate way. The discount cards that come off of the brand name drugs, such as for ADHD drugs, Concerta and Vyvanse, some of the EpiPens, because they're very expensive, some of the inhalers that we use like Symbicort and Advair, those ones have to normally go through, they're paid for and funded by the manufacturer themselves of the medication. And those ones have to go through your insurance first. So if they bill it to your insurance and you're in the deductible, the manufacturer will give you a coupon card that will allow you to bring the cost down to maybe $100 if you're in the donut hole, or maybe as low as $25 if you're into your regular copay scheme of either $47 or $63 based on whatever tier your plan puts that medication in. They pay, as I said, the benefits managers or those third-party processors to list the pharmacies. When the pharmacies sign up to be able to bill your medication to that plan and accept payment from them and allow you to walk out with the medication for a low copay, we sign a waiver for our name, image, and likeness. And the discount cards pay for that name, image, and likeness of all the pharmacies. So when you go onto the internet and you look and see what I don't mean to pick on GoodRx, but GoodRx says the price is this price. at Big Y Pharmacy. That may be true, it may not be true. There is a disclaimer that if you printed everything off on page 5 of 9, the disclaimer says the pharmacy sets the price. And I'll explain why those prices variances are different. But they pay them. And then the discount cards also pay the doctor's offices to list their coupons directly on the electronic prescriptions that are sent to the pharmacy. So sometimes if you went to like urgent care, you would get a prescription, the doctor would say, where do you want it sent? You tell them, of course you want to go see Eddie, so you send it to Walpole Big Y Pharmacy, and then you'll get a text to say, oh, use this coupon card. Well, you already have your insurance, but that's okay. Well, again, that doctor's office is getting paid by that discount card to at least put that coupon out there for you. The reason that the prices can be so different is that when GoodRx or any of the discount cards for that matter, whether it's ScriptSave or WellCare or any of those, when they use their prices, they sometimes use closed markets. So if they use a closed market pharmacy who can buy medication a lot less expensive than a retail pharmacy, such as our pharmacy, like the VA pays 25 cents on a dollar for the medications I pay full price for, or maybe they would go to a pharmacy, they use the pricing that goes to the pharmacy that only deals with geriatric services to nursing homes. They pay 60% of what I pay. They use those for prices, so they're estimating my cost lower than what it really is. And then they're also using closed market pharmacy prices for reimbursement. So if they went to a chain, let's say an Osco chain of drugstores, and said, you know, for all of the topical stuff will make you preferred, but you have to take $10 less on each tube, and they say, good, if you just say everybody only has to come to me, they'll use that price too. So that's why there's differences. I know that when people come in and we talk about, probably 20 times a day we get calls about that, and we try to do the best to give you the best price and value for your money. The manufacturer discount cards are the ones that I was talking about for, like the EpiPens and the inhalers, and they normally are good for 1 year from the day they're issued to you. They normally have to have the medication go through your primary insurance first, and they have a maximum dollar amount that they pay for. Now, a lot of those are going to be coming to an end, and that's because the Massachusetts Board of Pharmacy really doesn't like coupons, and I'll give you the 3 reasons why they don't. And most of it is for the benefit of pharmacy in general. They're not doing it just because they don't want coupons out there. They're doing it for the first thing, for diversion. If somebody's getting a medication and their copay on their insurance plan is $70 a month, but the discount card says they can get it for $20, they may not even use that medication. They would take it to the back alley there and sell it to somebody who's going to sell it on the street. And you may think that that's only for things like opiates and stimulant medication that has a use that's going to be for diversion. But any medication is. When I owned my pharmacy in Connecticut, I'm going to bird walk a second. My wife Linda loves when I do this. When I owned my pharmacy in Connecticut, I had the detectives come in from the town I was in looking to see if anybody was buying large volume of lisinopril, which is a blood pressure medication. And there was a shortage of lisinopril over in Asia. And so what they were doing is they were buying it at a pharmacy for $50 and then selling it in the hospitals in that country for thousands of dollars. So there's always a market for diversion. The second reason is that those third-party intermediaries, the pharmacy benefits managers, they want that money. They're saying, well, wait a minute, if I'm saying that the pharmacy should be getting $40 more and the discount card is taking that $40, I should be getting that money because I am the insurer. And most of that money that they take back in the form of coupons comes out of the pharmacy you fill your prescriptions at, whether it's us or CVS or Walgreens, any of those. And they're also trying to keep local drugstores open for business. The biggest problem with small independent pharmacies that only have one store, and I know we have one in town, Elaine and Walpole Pharmacy does a great job, is that they don't have the buying volume of 9,000 stores like a CVS does, or 13,000 stores like a Walgreens does. So she does the best she can, the independents do the best they can, and they have to have proper reimbursement to stay afloat. Getting back to what our Medicare D parameters are, We have open season for Medicare Part D. All of those of us that are on Medicare Part D over the age of 65. And it starts October 15th of each year and ends December 7th. So we have from October 15th to December 7th to change our plan if we want. Every single year we can do that. Now I know the Walpole Council on Aging has Shine come in and they do a wonderful job. You can do it yourself. You can go to medicare.gov, type in your medications, and it will choose for you at that moment in time what's best for you. And I say at that moment of time, and I'm going to reiterate that because that's important. Because you have until December 7th to decide what medication plan you're going to choose. For instance, if you're taking an inhaler that's costing you $64 because it's a tier 4, and you see that, oh, this other plan allows it to be tier 3 where it's only $47, meaning you could save yourself $27 a month, or $17 a month. I need to do math well. $17 a month for 12 months, that's a good sum of money. You're going to switch. Well, if 200,000 people see that same thing and sign up with the new plan for only $47 a month on their inhaler, that plan has until December 31st to decide what tier that's in. So if they see that 200,000 new prescriptions are going to come through for that one inhalant medication, and they're going to be losing $17, they're going to say, well, I'm going to make that a tier 4. And the pharmacy benefits managers have until December 31st to decide how much they're going to pay the pharmacies. So those negotiations will go on from October 15th all the way to December 31st. They decide who are the preferred pharmacies where you can get your 3-month supply instead of a 1-month supply. So at the end of the day, you have to choose by the December 7th, but those pharmacy benefits managers choose what's best for them by December 31st. It happened with us, unfortunately, this year. We were told WellCare was going to offer us a contract that we could accept on December 30th. They called and said, no, we're going to cut 25% off all costs, which we couldn't afford to do. So Big Y had to opt out of that plan, which was very sad, and you lose customers that way. There's another way to get your medication. It's mail order. Mail order normally gives you a 90-day supply. They ship it directly to you. Mail order has a little bit different rules because they know it takes time for the medication to get to you. So if you go to your regular pharmacy and get a 30-day supply, a 90-day supply, you normally can get it filled 7 days before you run out. With mail order, you can get it filled 25 days before you run out because they don't want there to be a lapse in your coverage if there's a problem with it getting to you. And here's how mail order works. The doctor would send the prescription to the mail order company, as this slide shows. They then send the information to the pharmacy benefits manager to say, Mr. Harold is getting Lanoxin. I'm going to give him 90 of those. Here's the prescription. And the pharmacy benefit manager pays the mail order pharmacy. And then at that point, they fill your prescription, stick it in the mail, and send it to your home. So it's a positive cash flow for mail order pharmacies. Most of those mail order pharmacies are not even in our state. So it's out-of-state commerce, which is fine, but I like to shop locally. So in summary to our talk today, and hopefully we've answered some questions, there's a lot of information that was thrown at you. Medicare D is a mandatory sign-up. We have to sign up. There is a 1% per month penalty for late sign-ups. So as I've said here, as my example on this slide, if you're late for 2 years of signing up, you pay 25% more. So that $55 price, you're going to add another $11 to that. So you would be paying $66 a month just for the basic plan. The pharmacy benefit managers set all the payment prices to the pharmacies. They set all of the costs to the patient, what the copays are, and how much you're going to pay per month for each of your policies. And we're going to take a step back for that. I did neglect to mention that you can pay more than the basic amount. The basic amount for this year was $55. You can pay more than that to make your donut hole go away. And you can pay more than that to make your deductible go away, and you can pay even more than that. You can pay over $150 a month to have even lower copays. I found serendipitously and anecdotally through doing Medicare since 2010, that if you hit the donut hole prior to July 15th, you're better off to pay more each month to get rid of the donut hole. If you hit the donut hole from July 15th to October 1st, it's kind of a wash unless you start a new, more expensive medication. And then if you hit the donut hole after September 1st, you're better off not to pay for it and just pay for the money when the donut hole happens, because you won't get through the donut hole until by the end of the year, by December 31st. So for your cash flow, it's better for you to just pay the basic plan and pay the amount of money that's due you in the donut hole. So we'll go back to this, that again, the pharmacy benefit managers set all the patient costs, they set the payments to the pharmacies, and they also set the pharmacy status. It's your option to change every single year. You have that option. Most people don't, but you do have that option to check. And if you want, you can always call us and we can see what we can do for you. Advantage plans can be lower cost for you out of pocket as long as you're not taking any very expensive medications. And those are for medications you're taking just to treat disease. Those will be best for you. The discount cards do charge the pharmacy to participate. The discount cards pay the PMBs to list the pharmacies even if they don't want to use them. And most generic medications will save you money, and your Council on Aging can certainly help you. So with that, I will put up a screen that just shows the different things that Big Y Pharmacy in Walpole offers. I'd like to thank you for having your attention today. I want you to be safe, be well, and visit us when you need to. Thank you very much.